episode of the AtheroTalk podcast. I'm Tatyana Storozhenko from the National Therapy Institute in Ukraine, and I will be your host for today's episode. In this episode, we are honored to welcome Professor Blankstein. He's a preventive cardiologist and cardiovascular imaging specialist at Brigham and Women's Hospital and professor of medicine and radiology at Harvard Medical School. He's also the associate director of the cardiovascular imaging program and director of cardiac CT. Professor Blankstein is internationally recognized for his work in cardiac CT, coronary artery calcium scoring, and risk prediction, and has published extensively on how imaging can improve prevention, diagnosis, and clinical decision-making in cardiovascular disease. He is also a past president of the Society of Cardiovascular Computed Tomography. Hello, Professor Blankstein.
Well, thanks very much, Tatyana, for having me on your podcast. And it's a real pleasure to be able to record it live from the EAS meeting here in Glasgow.
Thank you for joining us on AtheroTalk, and it's truly a pleasure to have you with us. And to start, we would like to hear more about your journey. What drove you to cardiovascular imaging and prevention? Was there a turning point during your training that steered you in this direction?
Well, even before going into cardiology, I've always been interested in prevention, in lifestyle, and exercise and nutrition. It's all a field that was very attractive to me. And philosophically, I'm someone who always likes to solve issues before they arise. So the philosophy of preventing disease very much appealed to me. And then I became a cardiology fellow, and I was explored or was introduced to the field of imaging. And imaging was fascinating because it used all this fancy technology. In imaging, to me, was a way to better understand disease. So with imaging, we're able to not just think about different disease processes, but to actually see them in front of us and understand kind of how this leads to different diseases. So I became interested in both, and ultimately along the way, I kind of discovered that it would be a really nice way to merge the two, because with imaging, we can see disease at earlier stages, identify risk better, and ultimately that leads to better patient treatment.
Thank you very much, Professor Blankstein, for sharing your story with our listeners. And is there a particular moment you can look back on and say, this made all the challenges worth it?
I think this is going to be a disappointing answer because I can't think of a single moment like that. I think training in medicine is a long journey, and there's a lot of moments along the way that are rewarding. There's, of course, a lot of moments along the way that are challenging, but I can't think of like one moment that I look back and say, aha, this is the moment that made it all worthwhile.
Okay, we know that you have managed to stay at the forefront of both clinical practice and academic research. How do you balance these roles, and what keeps you motivated?
Well, I like the variety of both seeing patients, doing research, and teaching others. And frankly, I don't think I would be as good at my job if I just did one without the other. They all kind of inform each other. So by doing research and being at the forefront of a field, I feel like I can bring that knowledge to patients that I see and ultimately to teaching. Of course, the challenge in doing that and wearing multiple hats is it does take more commitment and more time in being really vested in all of these aspects.
You have mentored many rising stars and in cardiology. What advice would you give to early career researchers or clinicians who are interested in cardiovascular imaging or prevention?
The general advice I give people is that no matter what you do, whether it's prevention or imaging or perhaps another specialty, is you want to be really good at what you do, because that will distinguish you and set you apart from other folks. And to be really good requires spending extra time, reading all the studies, going to conferences, and for many that means doing extra training beyond just a general cardiology training. The other advice is to find mentors who find the same passion and who have a track record for mentoring others. It's also important to recognize that at times there might not be just one right mentor, and you may want to put together a team of mentors And the team of mentors may have a combination of different expertise they offer. So for example, one might be a mentor in prevention, and one in imaging, and one in research, or one might be an expert in how to build a clinical program. And along the way, you're going to pick up different pieces and different advice from different mentors, and different mentors will serve you differently in different parts of your career. So I think it's important to kind of put together not just a mentor, but a whole team that can support you and help you along the way.
Thank you very much for this great advice. And so would you encourage young physicians to participate in international training programs or research fellowships?
Absolutely. I think once you've identified an area that you're interested in, spending extra time and doing a specialized training, I think, is incredibly important. It's what's going to help set you apart from others who may have a more peripheral interest. And certainly, if it can be an international experience and seeing how things are done in different parts of the world, I think that is even better.
You're widely known for your work in cardiac CT and coronary artery calcium scoring. Could you explain in simple terms what makes calcium score such a powerful tool in cardiovascular risk assessment?
Well, that's a great question. I think the one thing about calcium scoring is that it's very simple test. It's easy to acquire. You don't need the fanciest, latest CT machines. And you can do it in both major academic centers and also community centers. It has a low radiation dose. It's reproducible. So if you're doing the test here in Glasgow or back at my home in Boston or anywhere else, you're going to get about the same score. Aside from the score is the fact that this has been shown to be a robust marker which is strongly associated with outcomes. So the higher the calcium score, the higher the risk. It seems to be a very consistent and linear relationship. But on the other hand, the other aspect that's very important with a calcium score is not only can it tell us who's at high risk, but it can also tell us who's at low risk. We call that being a negative risk factor. So the fact that a calcium score of 0 identifies a very low risk group has been a really appealing aspect of this test, and one that ultimately made it very useful in clinical care.
And in your view, what are the main barriers to more widespread clinical use of coronary calcium scoring, especially in primary prevention?
I think the barriers are quite different in different countries, or even within a country in different locations. So they're very much dependent on a location. In my own center right now, for example, insurance companies are actually mostly paying for calcium score, but that's not the case in many other places. So certainly if payment is not possible, that's important because we want to be able to order a test in for patients, ideally not to be charged, even though in the US there's also been a market where patients pay out of pocket for it as well. In addition to the ability to pay and actually do the test, we also need data that shows us that the test makes a difference in how we manage our patient. And we now have very robust data indicating that. And that data has led to calcium score being incorporated in guidelines. And I expect that in future guidelines, we will see an even stronger role for calcium scoring in telling us not just who to treat, but also how aggressively to treat. Ultimately, if we have payment and we have guidelines and we have the research, the next step is always educating physicians, and it's not just cardiologists, of course, but it's mostly the primary care physicians, family doctors, and for them to know who is a good candidate for calcium score. And as importantly, when you get the results back, what do you do with the information? How do you use that to treat patients?
Innovation is a word we hear a lot. In your experience, what does true innovation look like, and how do you cultivate it?
Well, this is a really good question, because the reality is, and this is kind of the sad truth for someone who's done a lot of research during his career, that's me, is the fact that most research that we do, it adds maybe some small incremental data. It's not true innovative research. And that's okay. When we get started in research, there's a lot of important questions we can ask, but most studies that we do in research are not going to be the ones that are going to revolutionize or change the field. Yet it is important to have innovation. And innovation, first of all, means asking the right question. This is where, if you're a clinician, you may be at a better place to ask the right questions. It's also important to ask bold questions. When you ask a question, you want to go back and see if anyone ever tried to address this. And if, of course, there's a lot of publications on that, that's not a very interesting question. And if nobody has addressed this, you kind of have to think why that is. And when you ask bold questions, it is important to think outside the box. Often in medicine, everybody kind of thinks along the same way. And when someone has an idea that seems different, people's reaction, at least in some circles, is to knock it down. So it is important to think outside the box. And sometimes a way to do that is to bring together people who have different backgrounds. A lot of research is about teams. Research is done in teams, and assemble a really good team of people that have different strengths and weaknesses and ask good questions. And I think that is kind of the recipe to doing more innovative work.
As a strong advocate for prevention, what changes in healthcare system do you believe would have the biggest impact on reducing cardiovascular disease burden globally?
So in order to really reduce the burden of cardiovascular disease, we really need to start earlier in life. We really now have a model that is based on reimbursing for managing disease, not preventing disease. And the things we do now is wait for an event to occur, and once it's occurred, that's when we kind of start treating patients. What we need to do is identify disease much earlier in life. And in fact, we need to start lifestyle interventions, including exercise, diet, promoting more activity, as early as in elementary school and high school, decades before disease actually happens. I think that would have a big impact. Of course, this is something that many of us as physicians are not going to be able to advocate for alone. This requires better public health measures. So we have to start with lifestyle. We have to start it earlier. But then when it comes to identifying risk, I think this is where there's a very big opportunity with imaging to identify earlier atherosclerosis disease at earlier stages and identify folks who otherwise would not have been treated. And now, because they're higher risk, hopefully they can be treated more aggressively, both with pharmacological therapies and with lifestyle interventions. And earlier prevention, I think, is our goal. This is what's going to make the biggest difference.
And how can imaging and risk tools be applied equitably, especially in underserved or resource-limited populations?
Yeah, so of course it's a good question, because imaging is, by the nature of it, is expensive. Risk tools a little bit cheaper, but even risk tools, we don't do a very good job. So I think what we need to start with is risk factors that we can measure in everyone: cholesterol, blood sugar, weight, blood pressure. These are all things that should be measured and treated. If someone has elevated cholesterol, we should really think about why that is and how to treat that. Blood pressure is something that we really don't do a good job around the world treating. That should be treated. If there's obesity, to address kind of the barriers and the opportunities for treating that. So starting with identifying these risk factors, at least on a population scale, will be very important. Now, your question also has to do with imaging. And if we're thinking about imaging tools and populations that don't have a lot of resources, calcium score is probably the best bang for your buck. It's the least expensive of all our imaging tests. Often chest CTs are done for other reasons. So many individuals have chest CTs for other conditions. And if a chest CT is done, even if that wasn't a dedicated scan to look at the heart, often that gives us an opportunity to look at the arteries of the heart and see artery calcifications. Is there evidence of atherosclerosis? And being able to even just recognize disease on those scans, as we can now do with AI solutions, I think is very important.
And what current or upcoming topics in cardiovascular imaging do you find most exciting?
Well, I think imaging continues to advance. Across all modalities, there are advances in echo with respect to strain, with respect to AI interpretation of echo, with respect to selecting patients who are better candidates for various structural heart disease interventions. In cardiac PET, I'm very excited about the advances in quantifying blood flow and using that for both prognosis and diagnosis. I also do cardiac MRI, and certainly we have a lot of advances in MRI with respect to tissue mapping and identifying various diseases earlier on, and also quantifying the diseases. And then in CT, of course, we've seen a lot of advances recently In cardiac CT, one of the most exciting advances has been the use of photon counting CT, and this is a technique that now allows us to get much better resolution, much better spatial resolution, and it really revolutionizes our ability to detect various conditions. So when it comes to coronary artery disease, we can see plaque better, we can see high-risk plaque better, we're more accurate in diagnosing stenosis. And I think photon counting CT is going to completely revolutionize the field of cardiac CT. We're just starting to see publications showing the benefit of this. It's still not a technique that's available in most centers, but I predict that within 5 to 10 years, the majority of cardiac CT programs are going to use photon counting CT.
At the AtheroTalk, we have a section called the Graveyard of Ideas, where guests share a project, idea, or proposal that didn't work out, but told them something valuable. Do you have a story you could share with us?
I think every researcher has ideas that really didn't pan out. In fact, I've published hundreds of papers to date, and I think it's important to know that every successful idea, you have to have other ideas that didn't work out. If every one of your ideas kind of worked out and resulted in a publication, either you're publishing too much or not being too selective, but something is wrong with the process. So certainly I have a lot. I'll share, for example, I used to do a lot of work on cardiac sarcoidosis, and earlier on I submitted a grant to the NIH in the US for a big clinical trial in cardiac sarcoidosis. And the whole grant was shot down because there was no gold standard of how to detect cardiac sarcoidosis. So there was too much disagreement on how are we going to select our patients. That's just one example, but certainly a lot of examples of research that for one reason or another doesn't work out. And I think the advice I have for anyone listening is never get discouraged by a rejection. A lot of the good ideas get shot down for the wrong reasons. Sometimes they're practical reasons, sometimes they're lack of understanding of the field. Always move on. One of the things that make people successful is the ability to learn from failures and move on to the next project.
Thank you. And looking back on your career, what accomplishment are you most proud of?
Well, for me, it's probably the mentorship that I've provided others. I have been now for over 15 years a program director of our advanced cardiovascular imaging training program, and in that capacity, I have trained over 100 residents, fellows, and advanced imaging fellows in cardiac imaging. These are fellows who are now all across the world teaching other people, doing research and doing clinical work. My training has been not just in clinical imaging or clinical cardiology, but also in research, and those with whom I've worked with in research, and seeing their productivity and their contributions is incredibly rewarding for me. So that, without a doubt, is my biggest accomplishment. Sure, along the way, I think I've made some scientific contributions and guidelines, and those are always nice to see as well. And then I guess another one I would add is just being a good clinician and taking good care of your patients. At the end of the day, even if you produce research, which certainly has impact from a global scale sometimes, taking care of patients who are your patients, who are coming to see you, who are putting their trust in you, and being able to deliver that care at the highest level is something that's always been very meaningful to me.
It's very impressive, and that's very inspiring. For those who might want to train or work in your lab or imaging center, do you have any advice or how they should get in touch or apply?
Right. So different centers have kind of different requirements, and also it depends a lot if it's for clinical training or if it's for research. I think my advice is always to reach out, because you never know when the opportunity might arise. So in my center, for example, I run a program in clinical imaging for those who want to get clinical training. It's usually 2 years for cardiologists and 1 year for radiologists. One of my pieces of advice is to look early, because if you ask me, do you have any spots available for this coming July? I'd say no, we've already been full for a year. So you want to start looking probably a year to 2 years, probably 2 years before you're starting to think about it. Obviously, if you're going to go to a different country, you have to look about the requirements of what tests you have to do. So for example, in the United States, you'd have to redo this test called the USMLE in different steps. But different countries are going to have different requirements, so look into that. And then the other thing is to look at multiple programs, because one program might be full by the time you look at, another one might be open. So never put all your energy into one program. Keep a very broad kind of network and a kind of a broad list of places that you may be interested in.
Great, thank you. And Professor Blankstein, thank you so much for joining us today. It's been a real privilege to learn from your experience. And do you have something to say to our listeners?
Well, for last word of wisdom, I would say don't be afraid to kind of make your own track, your own trail. For me, it was often merging imaging and prevention, but for other people, sometimes it's merging other fields. For example, imaging was amyloid, or imaging was oncology, or prevention was rheumatology. So there's a lot of different pathways. And for some people, it's not just about one pathway. It's okay to explore several. But ultimately, it comes down to the fact that whatever you choose to do, invest time so you can be the best person there is in that field. The better you will be, not only the better physician and researcher and mentor you'll be, but the more fun you will have.
Thank you once again. And to our listeners, thank you for tuning into another episode of AtheroTalk. We always want to hear from you, so don't forget to share your feedback and let us know what topics would you like to explore in next episodes. Until next time.